Today was one of my anaesthesia days, and this means by losing the afternoon, I lose out on some of my short-term gratification type work, in and out, and doing that interesting work with the cardiac surgeons and the trauma, and think more about the chronic pain area of my work, which overlaps with the addiction area too, which is dealing with people on a much longer term basis. So Roger and Anne asked me to talk about the issues of chronic pain, older people, opioids, and over-the-counter drugs. This is a reasonably common clinical scenario that we see at the Royal Adelaide Hospital. We were asked from the pain clinic viewpoint to go and see a 93-year-old lady or 92-year-old, severe pain condition. It wasn't surgical. The surgeons had looked at her because she was so distressed. She was unresponsive to the usual short-term acute drugs there of oxycodone. She was really agitated, and when you looked at her, her background was as a nursing home resident, moderately demented but mobile. She had a long-term history of sort of aches and pains, and she was on a fentanyl patch of 150 micrograms per hour, which is, for those of you familiar with opiate dosing in people, it's a pretty massive dose. I mean, I think that's, if you think of it if you use the units that a lot of community understand, that's 100 Panadine Fort a day if the codeine was effective, or 500 of morphine. And the background of that was that she'd been on Panadine Fort previously, a few years before. It wasn't seeming to be effective. The prescriber, the GP, changed her over to a moderate dose fentanyl patch at 25 mics an hour, and it had rapidly escalated because there was short-term benefit and then tolerance. So the cycle went on. Initial benefit, dose escalation, then kept going. I was talking about this talk to my colleagues this morning, and the other people in the clinic said they'd all seen the same similar scenario on the wards at the Royal Adelaide, with the elderly person on the high-dose fentanyl presenting in agitation. The outcome, there wasn't major pathology with this person. The presumed diagnosis was opioid-induced pain and agitation. The drug was the problem. It settled with rapid reduction and cessation of the fentanyl dose, and it's a bit of we still have the battle when we go in there and we're from the pain clinic and they're asking us to treat the pain and we're saying, yeah, it stops the pain drugs. You know, it seems to be, they look at us like we're sort of crossed the line somewhat. But we're pretty comfortable with rotation to buprenorphine as being an alternative option at a much, much, much lower oral opioid equivalent dose. And when we communicate with the prescriber, which we try and do in a respectful manner without having a go at them, they were really surprised at the concept that the dose that they'd escalated to was so high, 500 milligrams of oral morphine a day. They wouldn't have dreamed of doing that, but it reflects the knowledge issue. And when preparing for this talk, this is one of the editorials that came out last month in the pain journals about optimal pharmacological pain management in the older adult. It's an ongoing quagmire. The more we learn, the more of a quagmire it seems to be. So how do we get here? I guess 25 odd years ago, we thought we could help people a lot better than we do now. This slide is the typical one that we hear. I think the dosage needs adjusting. I'm nowhere near as happy as the people in the ads. And to some extent, it's more a reflection of us as practitioners, that we're unrealistic in accepting the limited evidence that there was at the time. Patients certainly have a very high expectations, and we all want a silver bullet, and as a healthcare practitioner you want to help people, and we've had a believer that painkillers are painkillers, and that's what we've had the hard recognition that that's not quite true. What are we thinking these days, 25 years on? We've had our systematic reviews, our meta-analyses. We've got a numbers needed to treat of 2.5 at the best in chronic pain, so that if you've got your common or garden chronic pain issues of arthritis or back pain, if you're choosing opioids as your main analgesic drug, only 2 out of 5 patients will benefit in any way at all. 3 out of 5 won't benefit, and maintaining them on those drugs will not be of any help whatsoever. It will be causing harm. So the important thing to be doing will be, if practitioners go down that pathway, they've got to be confident about stopping them in the patient's interest. So we've banned the word painkillers. We say, well, the target that you're trying to achieve with these drugs is only about 20 to 30% pain reduction at best, and that's only if you're doing all of the other things, the exercise, treating the other health conditions, getting on top of the sleep issues, and that this should be a relatively moderate to short-term approach, such as weaning after 3 to 6 months before you get immune to them, because that's what we're seeing in the chronic non-cancer pain setting. In simplest terms, the evidence for benefit was far less than we all expected and hoped for, and the evidence for harm was far greater than we expected, and so we're learning to deal with that. So going back to the patient I talked about, what's the big picture behind this clinical scenario? There's lots of pain in the elderly, and it's often undertreated. Rapid escalation in opioid use has occurred in the elderly over the past decade. We're understanding far more clearly the adverse events associated with opioids and the fact that long-term or prior use of codeine for any length of time can have a pretty big impact on initiating tolerance. And basically get this knowledge out to the community and to practitioners, particularly with access to non-pharmacological options where we can see that benefit can be achieved without the same harm, is really important. Just looking at the prevalence, the ABS Health Survey review from the South Australian results. Don't know if you can see it down there at the bottom, but if you look at the common chronic conditions, something of the order of back pain's 240,000 South Australians, arthritis, pain, 270,000. The only other conditions that exceed that are hay fever and long-sightedness. If you ask South Australians what are their chronic conditions that bother them. If we go to Sweden, and I love finding papers from Sweden, in fact I'm thanking Roger and Anne for asking me to do this talk because I had to do all the literature review for my own learning, and it's been really good. This is stuff a lot of it's come out in the last couple of months even. So Sweden does great studies, 67,000 Swedes, mild to or no pain in almost 80%, 20% with moderate pain, 4% with significant chronic pain. They talk about health-related quality of life, and I can use this, yeah. If we're using this, we can see that, if you're 65 and fit, you've got a quality of life that they rated a 0.85. You're 85% of the best you could have been, maybe, which is pretty encouraging for those of us who will be heading there soon, if we can stay there. If you've got chronic pain and you're 85 plus, your quality of life is around about 20%. It's a pretty horrible life. So severe chronic pain really impacts quality of life. And they also talked about costs, which I won't go into. When we try and find out what happens in Australia, this is probably one of the better papers, Henderson et al. From the Sydney University GP Research Beach Group. So prevalence, causes, severity, and what are they doing about it in chronic pain in Australia. This is from New South Wales primarily, almost 200 GPs, almost 6,000 patients, 20% reporting chronic pain. That's the standard figure we keep hearing in our community. Arthritis and back pain being the commonest things. When you look at the age profiles though, of this group, 2/3 of these people are over 65 years of age. So of the people attending their GP and talking about pain, the focus is upon dealing with people over 65 years of age. And when you look at what gets offered and what was perceived to be what the therapies that were offered, medication only, drugs were the only thing thrown at the people in 56%. Which is a pretty unrealistic expectation of benefit from medications, because with the evidence so relatively thin that medication alone will cure the problems of the world, or at least chronic pain, it's not really offering the punters out there in the world a good option. What's being offered? Paracetamol, only for these arthritic and low back pain people, only in about 40%. Panadeine Forte comes in first place with over 2% of the adult New South Wales population, and the high popularity of oxycodone, over 1% of the adult New South Wales population. So probably the explanation for why, particularly in some other papers I was looking at for this talk, that of the prescription drugs that that are implicated in the prescription drug misuse. Individuals who end up under a dependency treatment program, Panadine Forte and oxycodone are the ones at the top, along with Nurofen Plus. What are the non-pharmacological things offered, or the non-drug treatments? Which is where working in a pain clinic where we have rehab doctors, physio, psychiatry, psychology, group programs, exercise programs, hydrotherapy. That's all the stuff we keep talking about. They're being offered to less than 4%, and 4% of patients are being referred. So realistically, our GP colleagues have got to deal with 96% of the chronic pain load with pretty limited resources available to them, where under our current model, PBS subsidies, writing a prescription is one of the simplest approaches to do. Other therapies are much harder to access and to offer. If you're in the States and you're an older person, you've got twice as many of you will have been prescribed opiates by 2010 as were being prescribed 10 years earlier. So the prescription rates have doubled for opioids in the older adults. And the difficulty here is sorting out, was this appropriate practice for those conditions where some regular, and certainly in the States the doses were pretty low when you look at this paper. 10 milligrams to 12 milligrams of oral morphine a day was their median, which was pretty low by our standards. It could have been the right thing in these individuals, or it might not have been. We can find this paper from here. In fact, colleagues at University of Adelaide, aren't they? Or University of... Yeah. So when you look at what's being offered prior to getting a stronger opioid, and oxycodone is classified as a stronger opioid, what are people being offered? Well, if you looked at these 11,000 DVA patients dispensed oxycodone in 2010, over a third of them had been offered nothing else but oxycodone. So they went from not being on an analgesic drug to a strong opioid straight away, which is a bit disturbing. When we look at the work from Roxburgh about prescriptions of morphine and oxycodone and how they've changed over the 6 years, 2002 to 2008, we could very much see that, if we can follow this, can I get there? Yeah. Morphine diminished, oxycodone went up very rapidly, and that brown line relates to the 80-year-old age group. And I get informed by colleagues that oxycodone certainly is preferred in the elderly because there may be less side effect profile. I'm not really clear about that myself. I think one of the major reasons is that there was fantastic marketing of oxycodone in the world. This is a great article from an American Journal of Public Health, the promotion and marketing of OxyContin, commercial triumph, public health tragedy. They use the term pharmacogeddon, which I think is a really good, powerful one. They were very successful in marketing despite a almost $1 billion fine for telling doctors that this was not an addictive drug. That $670 million fine isn't a lot because the quarterly spend on oxycodone or OxyContin in the USA in the first quarter of last year was $750 million. So that's less than 1/4 of the income coming in from this drug to Purdue Pharma. And one of the issues that we see is that some people seem to have a very much amphetamine-like effect from oxycodone, which may contribute to its likability. It's certainly different from the other opioids we get exposed to. I was again discussing this with a friend this morning, and he related the tale that a colleague had said, "Oh, yep, I had a wisdom tooth out a few days ago. They sent me home on endone. I've been up all night running around." The endone had really wound this 65-year-old up. Canada got rid of OxyContin because in some of the first nation reservation areas, 50% of adults were dependent upon OxyContin. Canada did it in a fairly abrupt way by cutting it off, and then there was a whole series of deaths from people seeking other medications. Looking at trends in fentanyl prescription and fentanyl-related mortality, again, this reasonably recent paper, 2013, from the NDARC team, was really focused on the fentanyl-related deaths in the younger IV drug-using population, which seems to be pockets, particularly in Victoria, both around Albury and then around Warrnambool, where fentanyl patches became the focus for drug misuse. However, again, they're showing a really rapid escalation in the older age group. So this is the 80-plus-year-olds, and this is the group who are just really getting more and more of it. And whether this is more to do with access to, from a nursing home viewpoint, we know that there's less nursing home staff available. Signing off on drugs with RNs can be difficult. A patch that only has to be changed every third day or every once a week, it does allow a little bit more flexibility in staffing rather than having to have 2 nurses sign off several times a day. As a clinician, we are nervous that people get very tolerant to fentanyl very quickly. These very synthetic opioids seem to be the ones that people get tolerant to. So I guess my biases are showing through that I'm pretty uncomfortable with oxycodone and fentanyl in these age groups. Just looking at some of the good US pain literature about what's happening, who's getting prescribed, and this was the association looking at mental health disorders, problem drug use and regular prescription opioid use. And if you took the people who at year 0 were not on opioids for pain, but they did have a mental health disorder of anxiety or depression, at year 2 they were 3 times more likely to be on prescription opioids long term than people who had a substance misuse disorder. An undertreated mental health disorder was far more likely to lead to prescription of opioids, and as Malcolm refers to, people present talking about their pain condition or their somatic conditions, they're not talking about their mental health disorder or their anxiety. This is some good work that's coming out of Australia. This is the 45 and up cohort. This group, they continue to study them. Fiona Blythe in New South Wales is a fantastic epidemiologist. So the PBS review of this 100,000 patients, of whom 20,000 ended up on opioids, some intermittent, 5% intermittent, 5% long-term, and 50% of their population that they studied were over 70 years. If you look at who ends up on opioids, to some extent, for those of us working in the older age group, the fact that being younger was associated with opioids is somewhat reassuring, and that they actually had a diagnosis that may or may not be useful having those medications. But the other factors were smoking, obesity and lower level of physical activity is the indication for why you're on opioids. Lower income, reduced private health insurance rate, higher levels of unemployment, living in a rural area and having higher levels of psychological distress. So these are all the social determinants why people end up being prescribed opioids by their doctors for a pain condition. Again, this is another group study coming out from the NDARC team, and this was published very recently in February this year, and they were doing a prospective cohort of some 1,500 patients dispensed opioids. And again, this is for chronic non-cancer pain. The association is primarily with psychological distress, poor general health, and having a lower income. So if you're poor, unfit and worried, you'll get prescribed opiates in our community. It just seems... The worry, though, from the older age group is if we're initiating this in the people who are 45 to 49 and we're not getting them off it, it's going to be interesting to see what it's like when they get older and they're in a nursing home, they're tolerant to opioids, they haven't had their other conditions treated, and we're looking at a big burden. So one of the other papers I dragged out was in fact from the University of Tasmania, and I haven't been able to find this published. I'm not sure if other people in the aged area have found it, but this was from a poster presented at a Asian Pain Society meeting in Singapore in 2013, and I met Felicity, the first author, was there, and she presented this data. I thought it was really interesting. So this group from Tasmania actually did they looked at the home medicines review data from 2010 to 12. They looked at a whole lot of data, some over 10,000, of whom almost 20% were taking regular dose opioids in the over 60-year-old group. 10% of that group were taking what we would call a very high dose of oral morphine equivalents, greater than 120 milligrams a day, and 50% of those are on the anxiolytics or hypnotics, which really does put them at risk, particularly in regard to their sleep or opioid-related side effects. Minimal use of paracetamol. Looking at the nursing home residents, again looking at solid numbers, 7,000, 11% of the nursing home residents are on a big dose of opioid. 28% of them were on opioids. Mean dose of oral morphine equivalent is around about 56 milligrams. So we're looking at 10 Panadeine Forte or 25 fentanyl, 12 fentanyl patch with a bit more, and oxycodone, 35 milligrams a day. The relevance of that number is that we can say that, well, this group are facing a twofold increase in fracture rate from that drug. That drug, more than 50 milligrams a day of oral morphine equivalents in this age group will give you the twofold increase in major fracture rate. So 1 in 10 of these individuals on this dose or more will have a fracture each year related to a fall, related to opioids. These are the factors that it's taken us 20 years to sort of gradually learn about these potent drugs we've been using. Some of the work that I find really interesting relates to what opioids do to the brain. This is some of the new functional MRI work that's coming out where from 2011, 10 chronic low back pain patients were initiated on oral morphine, less than 100 milligrams for 4 weeks. The drug was then ceased. A baseline MRI was done, and then at 1 month and at 4 months, and a control group was compared. And what they actually find is there's significant brain changes at that 4-week level. 4 weeks of opioids, some parts of your brain decrease in grey matter volume, other parts of your brain increase. The structural changes relate to the reward and emotional affect processing circuitry. The concern is that even though the drugs were stopped at month 1, or after 4 weeks, at 4 months the changes were still there. The changes were still locked in. They hadn't gone away. We don't know what that means, but it makes me nervous. The long-standing belief that we'd already been quoting is that slow-release long-acting opioids is a safer way to go. It's used in the addiction world for that sort of reason. We're beginning to get uncomfortable with long-acting opioids for the reasons that the longer-term adverse events seem to be no less. And we haven't been able to show that there are any improvements in safety, efficacy, quality of life, pain stability or sleep by using long-term slow-release opioids over short-term. It may be there, and certainly if people are going down this pathway, the doses need to stay pretty low, but we haven't been able to prove what we really believed. Nurofen Plus, I've got the picture up there because we asked to mention over-the-counter drugs. This one's from the picture from the UK. I don't think the Australian ones have got the 3 days use only bit at the top and can cause addiction. So if you buy Nurofen Plus in the UK, that's sitting there. The image at the bottom is about NSAID-induced gastrointestinal toxicity. We see 2 or 3 of these a year at the RA. We hear of them from all our colleagues at each hospital around Adelaide. We hear of 1 death per year in Adelaide of someone in their 20s who, and more often female than male, and more often working. And Nurofen Plus is seen to be a safer approach in the perception of these individuals. 96 to 100 tablets a day on a long-term basis is what we hear about. And one individual had 7 presentations to the RAH over 2 years before the substance misuse was actually tracked down. And we're getting really, really concerned. And, we're talking about codeine, and what are we learning about codeine? This paper came out from a group at Adelaide Uni. Mark Hutchinson is a really prominent researcher about hyperalgesia induced in rats, I think it was, but with codeine and glia. And glia is the inflammatory markers that come along when people get exposed to opioids. Glia may be the factor associated with tolerance, with dependency. And it's interesting that 30 milligrams of codeine will activate the glia as much as 30 milligrams of morphine. So despite the fact that codeine is very weak, it will actually activate the neuroinflammatory response, the tolerance effects, and the potential dependency effects as much as morphine dose for dose. So regular use of codeine for mild pain conditions, such as headaches, whatever, will lead to increased pain sensitivity as much as larger doses of strong opioids. So I'm not going to have any beefs about short-term use of codeine, but once it's being used on a longer-term basis, we will have significant issues. Almost finished. What do we think about codeine? Well, we're not going to be able to get rid of it, but it is an unpredictable prodrug. It doesn't have any conversion to morphine in about 5% of the population here, and in the other 5 to 10% of the Australian population, they may be getting milligram for milligram morphine effect. So a 30 milligram of codeine tablet will be the equivalent of 30 milligrams of oral morphine. We can't find evidence of benefit in any of the meta-analyses, and it wouldn't get on the market now. And the concern about the fact if it's been used in the long term, whether it's a factor for initiating dependency, which then becomes particularly toxic when combined with the use of an NSAID. Moving on quickly, I mentioned buprenorphine because we do seem to be having less adverse events with buprenorphine. The kappa antagonism part of buprenorphine does seem to be associated with lower hyperalgesia, lower glial activation, less tolerance, so it may be a better choice. So I've said all these negative things about medications. I've talked about trying to offer non-medication approaches. There are increasing options available. They're not necessarily readily available in the aged care sector. That's the goal that we have to work on, how to get availability of non-sexy, non-pharmacological approaches that take work on behalf of caregivers and of individuals. We've got pain in residential aged care management strategies. This came out in about 2005, and I know that the Pain Society is rewriting this at the moment. We've got good literature these days for self-management interventions for chronic pain in older adults, RCTs coming out of Sydney by a very strong group where there were significant improvements in pain, disability and distress. We've got over internet-delivered CBT pain programs for similar things. So in the ideal world for our patients and for the 93-year-old or 92-year-old I referred to initially, we'll have a prescriber out there, a GP who's confident about pain management. They've got a good skill base, but they've also got the time available to work their way through it. We're going to give repeated doses of medical consistency, the same positive message to our people out there, so that we know that people can deal with their chronic pain, not always needing medications, and that the prognosis is often good. We want to find ready access for self-management tools and skilling up the practice and aged care nurses to be able to help the punters or the patients out there. We need to get more access to community pain, skilled allied health for pacing, exercise, coping skills, and we need to work out the best quality use of analgesic drugs, which we haven't quite worked out yet. Thank you.